apparently you do. So I was asked to talk about inflammation in adipose tissue and how that could relate to type 2 diabetes and obesity and insulin resistance. And of course, it's always a challenge to be the first speaker on a meeting because people are still awake and eager to learn. So I try to do my best to be as clear as possible. And I'm, as most of you, a doctor. I'm an endocrinologist, and I mostly do human research. So I mostly present human data and sometimes animal data when they sort of support the human data, not the other way around, which is more common. And I think first we could have a history lesson. When did we know about adipose tissue being inflamed? Well, the first and very seminal paper came in 1993 from Boston by Gökhan Hutamisligel and Bruce Spiegelman. They could show that mice released from adipose tissue into the circulation a lot of tumor necrosis factor alpha. And they could show that if you blocked that with an antibody, there was an amelioration of the insulin resistance in these obese animals. And they postulated that inflammatory signals from adipose tissue could be important. We did the second study together with them because we had human clinical material and could show together with these people that there is also production or release within adipose tissue, in human adipose tissue, increased in obesity and then decreased in after weight reduction. However, there is a clear difference between human and mice, which tells you can't only rely upon animal data, because another group showed some years later on that there is no release from human adipose into the circulation of tumor necrosis factor alpha. It's a local factor. So in humans, TNF-alpha, it's working locally and indirectly signals to the environment, whereas in animals or rodents at least, it's a direct signal. So one has to remember that during my talk. I will come back to these things many times. This is the second sort of breakthrough in inflammation. Came about 10 years after the Boston paper. Two groups in Journal of Clinical Investigation showed head-to-head that in the obese adipose tissue there was infiltration of macrophages. And the more infiltration of the macrophages, the more dysfunctional was the adipose tissue. And these papers have also been very well cited, particularly the paper showing that there was the same situation in humans as in animals. And I think, although not so much cited yet, I think this is also the third breakthrough. It was from a French group, Karine Clément and her colleagues. They could show also, these were human studies, that the adipose tissues become fibrotic also. So in connection with the infiltration of macrophages, there's also fibrosis. So it's very much like, in particular, you know, the inflammation in the liver, where it's inflammation and then infiltration of inflammatory cells, and then comes the fibrosis. So I think it could without any doubt to be established that the adipose tissue becomes inflamed when you are obese. But the question is, of course, is this just a parallel phenomenon of little clinical importance, or is it really a pathogenic factor in type 2 diabetes and insulin resistance accompanying the obese state? Well, this is of course very important to find what is the first step in inflammation. How does this start? And one can say we really don't know that because it's extremely difficult to show it. But there are two factors which are very much, when you see it on top, two factors which are very much tumor necrosis factor alpha and large fat cell hypertrophic adipocytes. If you go from a lean state to an obese state, there is increased TNF-alpha, I said that before, the fat cells become enlarged, and that brings up lipolysis and fatty acids and brings down adiponectin, which is an endocrine signal from fat cells to the insulin active system. It's an insulin synthesizer. So both these factors, TNF-alpha and the hypertrophic adipocytes, they are the earlier event, and that turns on what comes down in the lower part of the figure here with inflammatory cells, and it's not just macrophages, others as well, and a number of pro-inflammatory and inflammatory proteins are produced by the different cells within the adipose tissue. That tumor necrosis factor can cause increased fat cells is rather certain, at least in animals. We showed in a paper some years ago that, contrary to earlier belief, fat cells are not in a steady, in a resting state when you are grown up. It was previously thought when you make your fat cells when you grow up, and then in the adult life they are sitting there and being filled or not. But we could show with a special technique that there is a rather high turnover of human fat cells. About 10% of your fat cells in your body every year are renewed and replaced with other fat cells. And in a subsequent study we could show that if the turnover of these fat cells is decreased, then you develop this situation in adipose tissue with large hypertrophic fat cells, independently if you are obese or not. So, and it's very tempting to say that this is at least partially due to TNF-alpha, because I will show you later on that TNF-alpha, it really alters the turnover of fat cells, because it can influence proliferation and differentiation and breakdown of fat cells. So if you have much TNF-alpha, you get slow turnover, and you produce a lot of large fat cells. But when it's high, little TNF-alpha, this turnover goes rapid, and then you have many small fat cells. So this could really, what is the hen and what is the egg? We don't know. But it could be so the first, by overeating or inactivity, that adipose tissue produces more TNF-alpha, and that increases the fat cell size according to the mechanism I just showed. Or it could be so that the fat cell size increases because you eat more and you fill up the fat cells, and that in turn cause increased TNF-alpha. But both, regardless of what is the first step of these two events, inflammation is the consequence. This is another very, very early event which is important. And here, the first time one could use human studies to show something novel. We did a lot of studies on secretion of proteins from adipose tissue. We could find in human fat cells that they produce monocyte attractive protein 1, or CCL2, from the fat cells. And the larger the fat cells, the more they produce. And CCL2, it really attracts the monocyte from the circulation so that they go into a tissue like adipose tissue and become macrophages. So we suggested that this could be a very early event. But of course, as in human studies, always associations. But then came very elegant animal studies where they sort of knocked down CCL2 in an adipose tissue specific way. And then they could show that there was much less inflammation, and the obese animals were less sick than those who had a normal sort of function. So CCL2 is a very early activation of that one. Is another early event in starting the inflammation. Inflammation is under rather tight control. It's not just going on in an unorganized fashion, at least not in humans. So when we became interested in this, we did some reading on rheumatism. And in rheumatism, if you rheumatic tissues, inflammation is controlled by a network of transcription factors here to the right, proteins that binds the promoters of genes and regulate their mRNA production, and microRNAs, small RNA molecules that cannot be transcribed into proteins but are binding to genes like transcription factors and regulate the mRNA levels. And that was shown in inflammatory tissue, in rheumatism and other inflammatory conditions. That's important. So we just looked in adipose tissue if these events also are important. And they are indeed, and in adipocytes, this is like an amplification network. It's very complicated, as you can understand, to dissect this, but we have done at least some dissection in a couple of papers we published recently, and we focused on this CCL2. And you can see here, there are certain microRNAs that can act directly on CCL2 and increase its production, and others through transcription factors. And when you combine these two, it will be an amplification. It's not 1 + 1 is 2, 1 + 1 is 3. So you can amplify, but you can also amplify at lower steps. Here's another transcription factor working on microRNA working on 2 transcription factors. And if you combine these two, you get 1 + 1 = 3. So that at different levels, you have an amplification of these networks. And they are specific for the fat cells, because if you take the macrophages, there's also amplification, but in other pathways. So adipose tissue can really fine-tune its regulation, inflammation, because that's important. Because if you look at each of these steps individually, very tiny effects, but when you combine them, you get some rather dramatic effects. So is inflammation is it bad or good? You can say. I mean, most people until very recently thought it's really bad for you to have this inflammation, but I don't think it's that simple. I mean, this is what people used to believe, that you have obesity, a lot of inflammatory cells there, and the adipose tissue goes astray. However, we did a study, a rather courageous study. We took young women, slender young women like you, women here, and persuaded them to give a lot of adipose tissue with biopsies. It was not so easy to persuade them to do that, but they were completely healthy, 25 to 30 years old, and then we measure TNF-alpha, which we think is the really bad guy here. You can see there's a very nice correlation between, this is the size of the fat cells. Those are very large fat cells corrected for body fat, and small fat cells, but it's a really linear relationship. It's not that it's a yes or no question. So we proposed in this little paper that it might be so that you need to have inflammation to have a normal function of the adipose tissue, and that was really confirmed a couple of years later on by this study by Phil Scherer. He's an excellent animal experimental researcher in Texas, and he can make all kind of complicated animals, and I have no time to exactly tell you how he did this animal, but he constructed a mouse that couldn't be inflamed in adipose tissue upon high fat feeding, and that mice really developed all these complications with insulin resistance and deposition of lipids outside the adipose tissue, so forth, upon high-fat feeding, whereas the control animal that could develop some inflammation was much less affected. So he concluded from this study that indeed inflammation is important in mice. Unfortunately, it didn't cite our paper, but now it's shown both in mice and man that inflammation is probably not just a bad guy. So it's a little bit like this. It's like Dr. Jekyll and Mr. Hyde. Some inflammation is good for you, much is bad. But no inflammation is also bad. I think it's like blood pressure. If you have 0 blood pressure, I think you are in a bit of a trouble. But you have too high blood pressure, you're also in a bit of a trouble. Or heart rate, 0 heart rate, I think we all don't want to have that, but too high heart rate is also bad. So we need a certain level of the inflammation to keep fat cell happy, or adipose tissue happy. So I was supposed to say the link between adipose tissue inflammation and fatty acids and insulin resistance. And is there a link? There are not too many studies published on that. But if you look at it on the left part of this figure, where you have TNF-alpha, how it's acting on adipose tissue, it acts on two things. First, it produces large fat cells, and that by itself increases lipolysis, but it also stimulates lipolysis directly. There's 2 effects. I will come back to the more molecular mechanism very shortly. So we did a translational study together with a French group, Dominique Langin, in Toulouse, where we did the human studies and he did the animal studies. And you can see to the right, a cross-sectional study. We had a lot of people where we taken adipose biopsies and just measured lipolysis, a breakdown of fat in these adipose tissues. And then we did an insulin tolerance test, a simple test, but still it's a pretty good measure of insulin resistance. You can see here that's a negative correlation. That means that the higher lipolysis, the more resistant, and those with low lipolysis, they are very sensitive. So that was cross-sectionally. But we also did longitudinal studies, and you can see to the left, we took people before or after bariatric surgery. Weight loss improves insulin sensitivity, and the improvement of insulin sensitivity is positively correlated with a decrease in lipolysis. But the most important part in this part of the study was the animal studies, where the French people gave rodents a specific inhibitor, which we have developed, of lipolysis. And you can see on the upper part that if the animal treated with this inhibitor, much lower lipolytic levels than control animals. But you can also see that they have an improved insulin tolerance test, the same test as we did in humans, as compared to those receiving just a saline. So I think this is a pretty good evidence, both in animals and in humans, that higher rates of lipolysis are associated or cause insulin resistance. Here are other studies, which human studies, the correlative studies, but still I think rather suggestive. To the left, data we haven't published yet. We took adipose tissue, measured the secretion of TNF-alpha from adipose tissue, and correlated with HOMA. That's a simple but still effective measure of insulin resistance. The higher the secretion, the more resistant are the subjects. These are non-diabetic women, but we did the same type of study recently in diabetics. And here we could see that there was a correlation between how much adipose tissue is produced, this TNF-alpha, and the rate of lipolysis. So these two together sort of suggest pretty strongly, I think, the correlations are very strong, that there is really a role of TNF-alpha in adipose tissue, of lipolysis, insulin resistance, and maybe diabetes. Well, I'll come back to the maybe question pretty soon. So if fatty acids are important for insulin resistance, and so then what's the relationship between circulating fatty acids and insulin resistance? Well, here I must say that this sort of may speak against what I have been talking so far, because the relationship is almost non-existent, at least if you take fasting levels. This is, you see, it's a very large study we just published, about 3,000 people, where we have lean people with or without insulin resistance as HOMA. You see, there is no differences in fatty acids or in glycerol, the two end products of lipolysis. And if you take the obese one, insulin resistant, there's a tiny little difference. But of course, we cannot explain, we cannot really claim from these studies that it's important at all. But you have to remember, fatty acids are really hard to study in terms of what do the levels mean, because it has been known, well, since ages. This is, I think, the first paper I could at least find, where they measured, every hour throughout the day, fatty acid levels, and you can see, they are really going up and down, and depending on the diet. If you eat a lot of glucose, low levels here, and normal diet, it's really biphasic. So it's very, you can't just rely upon what goes on here in the morning when you do most of your studies. To really understand it, you have to do these extremely cumbersome studies over the night, and no one has done it in this context. So I still think that it is the concept of fatty acid is still very valid. So this is at least how we think inflammation is linked to diabetes in the obese. We think TNF-alpha is really the important factor here. It's secreted not only by macrophages, but also from fat cells or precursor cells of fat cells. So a lot of cells in adipose tissue release TNF-alpha. But it's in humans a local effect. So what this TNF-alpha does, it sort of produces large fat cells by altering the turnover in one way or another, and that in itself increases fat cell size and increases lipolysis. But then there's direct TNF-alpha on lipolysis, I come back to that, which also increases lipolysis. So you get an increased release of fatty acids from the adipose tissue, and that can impairing insulin action. Many groups have shown that elevation of fatty acids that causes acutely insulin resistance in humans, in animals, or whatever. And that has also been shown, at least in animals, that fatty acids inhibits insulin secretion. That was a classic paper by a Swedish guy, Valdemar Grill, for 25 years ago or so. So impaired insulin action and decreased insulin secretion, that's type 2 diabetes, isn't it? And how does TNF-alpha work on the molecular level? Again, this is on lipolysis. There is human-specific effects. In humans, we found that it's TNF-alpha receptor 1. In rodents, TNF-alpha receptor 2. And another group, Andy Greenberg, found also a human-specific signal here. But what the take-home message is that TNF-alpha acts on the lipid droplet. Human fat cells, it's just one big lipid droplet. And that sits in a bag of a protein called perilipin. So what the TNF-alpha does, it sort of breaks up the perilipin, makes sort of holes in it so the lipases can chew up the triglycerides. But then we also have to consider the effect on fat cell formation. Don't think the molecular mechanisms are exactly identified, but it can inhibit the going from a precursor cell to a pre-adipocyte to an adipocyte, but it can also stimulate the reverse reaction, a de-differentiation to precursor cells. So these two effects on TNF-alpha we think are important. There are also genes directly involved in this respect. We did a study recently, we published, that we found a transcription factor called EBF1, and this is the same picture as just recently showed you. And we did a very comprehensive study on animals and humans, and we could find that low levels of this EBF1, it causes hypertrophy it does cause it in the mice, but it also associated with hypertrophy as large fat cells in humans. And it increases lipolysis. We could show that both in both species, and it causes insulin resistance, directly shown in mice and indirectly in the humans. But we could also show in both species that TNF-alpha alters, decrease the EBF1 expression. So we think this is one of the most important maybe genes in regulating inflammation in adipose tissue. And it does so in two ways. One on the differentiation that was shown before in rats and by a Rosen group, but we could confirm in humans it's working on PPAR gamma and CEBP alpha. These are the two most important regulators of making fat cells. But what we could find in our paper also that it acts directly independent of this effect on the precise mechanism how fat is broken down by the perilipin and the lipases. So two different effects, but both going to the same direction. And this is regulated by TNF-alpha. And we were very pleased to see this paper came out a few years ago when they did a genome-wide association study on patients with and without metabolic syndrome. You can see what pops up, EBF1, polymorphism, that one, with those extremely low p-value, genome-wide significance. So, there is pretty much evidence of the role of EBF1 for inflammation and so forth. So this is how we think now. TNF-alpha is produced within adipose tissue. It works on, it acts on the EBF1 transcription factor, and that slows down the making of small fat cells. You get large fat cells. And in addition, it acts on EBF1, so you get increased lipolysis. What about regional differences? As you know, adipose tissue, a lot of people are interested in the visceral fat, which is has direct link to the liver, to the portal system. So is inflammation more sort of prominent in visceral fat than in subcutaneous fat, you might ask? And I would say that's a bit of a controversial issue. If you go from lean to metabolically healthy obese, to obese with metabolic syndrome, and to obese with type 2 diabetes, we did, I think, the first study on comparing these, and in our hands, it was much more prominent inflammation reaction in the visceral fat. However, then came another study, which I think was more careful than our studies, better selected patients in Journal of Clinical Endocrinology and Metabolism by the French group, Dominique Langin, and they found that was the same effect of inflammation in the two depots when you went through this these stages. So taking the papers, and there are other papers also together, one probably could say that it's not a qualitative difference. I mean, it's inflammation in both depots, and it might be in some patient cohorts a little bit more pronounced in the visceral fat, and the others there is no difference. So the take-home message is that it's not a regional thing by itself. It might be some quantitative differences. So now I'm reaching the end of my talk. Is this really clinically important? Am I telling you a story which you could forget by the coffee break, or is it really important? So I will tell you some prospective studies on inflammation and adipose inflammation that are published, and some treatment studies. These are two papers I know where there is evidence that prospectively that if inflammation is really linked to type 2 diabetes. This was a diabetes paper many years ago, where they looked upon circulating level on two inflammatory markers, CRP and IL-6, and both are produced by adipose tissue, in particular IL-6. Some people believe that IL-6 adipose is a major producer, really. And they looked at those in combination with TNF-alpha receptor 2. It was not, TNF-alpha didn't give anything, but the receptor gave. So if you have an elevated level of TNF-alpha receptor and IL-6, or TNF-alpha and CRP, the risk of becoming type 2 diabetic in the future was very much elevated. So this is, I think, is rather nice prospective study. This is another, I think, even nicer study. It's a meta-analysis of patients with rheumatism. You know, that's now one of the most important treatment strategies, to give rheumatic patients anti-TNF-alpha antibodies, TNF-alpha antibodies. And that, you see, the risk of becoming diabetic is very much reduced if you are on the treatment, or if you get other types of treatment. So I think these two papers do suggest that inflammation, maybe not just in adipose tissue, but inflammation is really something which is causally related to development of type 2 diabetes. If it's a treatment target or not, I think it's a little bit of a different bag, because data are, well, I'll go over the data. You can make your own conclusions. I will look at anti-IL-1, because IL-1 is also produced by adipose tissue. It doesn't have so much effect by itself in adipose tissue, but it's suggested as a very strong inducer of type 2 diabetes, has been suggested in animal studies. And there's also, salicylates, that have been used them for hundreds of years to treat rheumatic conditions. There are data on that. And there is also, of course, data on anti-TNF-alpha treatment. And finally, to inhibit lipolysis directly, because since lipolysis is sort to be involved here. So what goes on in these studies? I think the most promising one are where you have treated IL-1 either directly with antibodies, or the receptor, anacrina, there's an antagonist. There was a very nice paper some years ago in New England Journal of Medicine, really showing that that was an improvement of glucose control and beta cell function, and decrease the inflammation of this when you treated them. But of course, there's no outcome studies. Today we have to have outcome studies to really start a new treatment. And of course, it will be very expensive. But I think these data are probably the best. Then you go step down to the salicylates, and there is maybe others, but the most important one is this trial when they had a derivative of salicylate, salsalate, which less side effects, and that improved glucose control in type 2 diabetics, but there was no effect on inflammation. They looked directly into vascular inflammation. So I would say it remains to be proven if that one will be used or not. Then anti-TNF-alpha, there is a lot of negative studies. There is not a single positive one. They have given it as one shot and several shots, and nothing happens with insulin sensitivity or glucose control. But you have to remember, as I said in the beginning of my talk, that in humans, TNF-alpha works locally. So it may be so that just reducing TNF-alpha in the circulation will do very little, because you have to attack the adipose tissue directly. So, but the studies so far with anti-TNF-alpha are negative. Then, what about inhibiting lipolysis directly? Well, for the moment, there is only one drug available, that nicotinic acid and its analogues. However, if anything, they worsen glucose metabolism. So of course that they do not work. But on the other hand, we have to remember that nicotinic acid has some effects not related to lipolysis. You know, it's an anti-lipolytic agent, but it has direct effect on the liver, for example, and on the muscle. So it could be so that it has a sort of yin-yang effect. And also the anti-lipolytic effect of nicotinic acid disappears after a while. It's like tachyphylaxia. So to sum up the most important part of my talks, I mean, there is local inflammation in adipose tissue, but I think you need it for normal function. But if it's increased, then it's pernicious. And what triggers inflammation is enlarged fat cells and or increased TNF-alpha production. And these factors are governed at least by one transcription factor, EBF1. And increased fat cell size and increased TNF-alpha production, that accelerate adipose lipolysis, so more fatty acids are available. And if you have more fatty acids, then you are insulin resistant, impaired beta function, and alternatively, that could contribute to that type 2 diabetes development. And there is indeed clinical evidence for the role of TNF-alpha in inflammation and type 2 diabetes, but direct inhibition of TNF-alpha is not effective so far. But there are clinical trials, in particular on interleukin-1, that are beneficial. So maybe we will see the drug development in that respect. So thank you very much for your attention.